My name's Claire Austin, for those of you who don't know me. I'm Pro Vice Chancellor and Dean of the Faculty of Health Science and Medicine here at Edge Hill University. And it gives me great pleasure to welcome you all to this evening's inaugural lecture given by Professor Adam Watts. So just to say a bit about Adam, he joined the university last year as a clinical academic in our medical school here. He's a Professor of Orthopaedics here at Edge Hill, an Honorary Consultant Orthopaedic Elbow Surgeon at Wrightington Hospital. So Adam's had a distinguished career starting in London, where he studied medicine, and his training followed in Edinburgh, Australia, and then back to Wrightington. And he's got a PhD from the University of York. So Adam's a very experienced researcher with clinical and research interests, including the treatment of degenerative joint disease, sports injury and trauma, with a focus on minimally invasive surgical techniques and joint reconstruction. And I had to write all those things down. He's established the musculoskeletal research group here at Edge Hill, bringing together colleagues from across the university, so it is really interdisciplinary, with a shared interest in frailty and orthopaedics and in musculoskeletal interventions. Adam's got over 130 publications, according to your CV, and has been awarded significant grant funding, including that from the NIHR, and he holds national research positions, and he's internationally and nationally known and well respected. His CV speaks for itself, but I'd just like to highlight two things about Adam, really. Firstly, the research he conducts has real impact on patients and on services. I think that's so important, because research should not be an academic exercise. Research, for me, is about evidence-based practice and advancing service delivery and treatment. And I'm sure Adam will tell you a lot more about some of the work he's done in today's lecture. But something which he might not talk about as much is the work that Adam's done and continues to do in supporting research development in others. He has, until very recently, been Director of Clinical Research at Wrightington and Wigan and Lee, Teaching Hospitals NHS Trust, to give it its full name, where he's been instrumental in the growth of research and of the further embedding research within the Trust. And at Edge Hill, he holds the position of Director of Research within the medical school, and despite the fact he's not been in that post long, he's already leading positive research development within the school. Adam's really committed to strengthening research collaboration between Wrightington, Wigan and Lee and Edge Hill University, and that's so important. And he's doing that by developing research capacity across the two organisations and maximising the impact of, or the clinical impact of research. He leads by example as a researcher. This lecture is an opportunity to hear more about his journey and the work that he's done. So you've all come here to hear from Adam tonight and not from me. So Adam, I'd like you to deliver your inaugural lecture entitled Innovation in Orthopaedics, Trial and Tribulations.
Thanks very much, Claire. A very nice introduction. It's very kind of you, and it's really an honour to give this lecture this evening. A great pleasure to have joined the faculty here at Edge Hill University. A great honour for me as a clinician and as a researcher. It's great to be with you. So I'm an orthopaedic surgeon, and normally my talks are full of blood and guts and gore, but I've taken those out. And apparently that's disappointing, so I'm sorry that there's not going to be blood, guts and gore, but I wasn't quite sure how that would be received by all the audience. Do I need to switch that on? Not advancing. There we go, just slow. So there is a view amongst clinicians that orthopaedic surgeons are somewhat Neanderthal, and my use of digital technology maybe supports that perspective. And it's true. I mean, I wouldn't have described myself, certainly at this age, as being bookish. In fact, my first school report read, "I've absolutely no idea what to do with Adam. He's in a world of his own. Doesn't concentrate, is in a constant daydream." But sometimes, actually, daydreaming and using your imagination could be a good thing. And we'll explore that over the subject of this lecture. So I'm going to talk about innovation, how the purpose of it and how we do that in orthopaedics, the framework that we use, and then give some examples of some surgical trials that I've delivered. And then briefly at the end, we'll touch on the new directions and where we're hoping to go with our research in the future. The first question is, why the elbow? I was going to get my youngest son, Hayden, to help me out here, but very sensibly he's declined. You know, my passion is the elbow. I started off in my career doing shoulders down to fingertips, but my absolute passion is the elbow. And there's a very good reason for that. And if you think about the elbow, it's a very neglected joint. But we quite happily, quite merrily, my clinical colleagues in the audience will attest that we're quite happy to fuse a wrist, get rid of that joint. People will manage absolutely perfectly well. We're quite happy too to fuse the fingers. People will manage well with that. Ankles too, and toes, you can fuse those. People will be able to function perfectly well. They'll be able to move around. You can fuse the lower spine, you can fuse the neck, no problems. People will be able to function absolutely fine. You can fuse the shoulder. We don't often, but there are some situations where we might want to do that. And again, people can function perfectly well. More rarely hips and knees, but again, people can manage surprisingly well to ambulate with fused hips and knees. But the one thing you absolutely can't really manage with if it's fused is your elbow. So if you imagine your elbow stuck out here, occasionally we have patients with head injuries, they're nursed in the intensive care with the arms in this position. They create lots of bone around the elbows and the soft tissues, and they're stuck like this. They can never reach their mouth, they can never wash themselves, and it's completely disabling. So I would argue that the elbow is absolutely the most important joint in the human body. It enables us to feed ourselves, to bring objects from afar towards our mouth. But it's also a little bit fickle. As has been described, it's a bit like a spoiled child. It needs delicate care. If you treat it wrong, it behaves badly. And that is a big reason that a lot of people don't like elbows. They're quite happy to send the elbows to somebody else because it gives a lot of problems if you don't get it right. But for the same reason, we have really an underserved population here because people aren't interested, they're not researching it, and it means that the patients are not getting the best care that they deserve. And so, for me, that is an area which was really ripe for further investigation, and an area where I felt that I could make a difference and try to improve things. When we think about innovation in orthopaedics, there is one person who is absolutely at the top of everybody's minds and everybody's lists, and that's Professor Sir John Charnley, who worked and practiced at Wrightington Hospital. He invented, through significant trial and error, the first successful metal on polyethylene hip replacement, which has really been the forerunner for all modern joint replacements throughout the body. A really fantastic achievement, and his work put Wrightington Hospital on the map internationally, and is a reason why people choose to come to work at Wrightington, and why patients choose to come and have their care at Wrightington. But Sir John Charnley didn't. He was very diligent in the way he collected data. It wasn't just by chance that he emerged on this design of hip replacement. He went through lots of iterations of different materials, different designs, before discovering the material that worked. And he was dedicated to his patients, and his patients were so dedicated to him that they agreed that even after death, they would provide material for his research. So they agreed that their hip replacements could be removed and sent back to Sir John for him to analyse to see how they behaved. But it was that diligent, careful attention that enabled him to innovate, and that's a really important lesson. The other really important lesson is that if it ain't broke, don't try and fix it. So if you've come up with a solution that works, then don't fiddle with it, because you can only make things worse. But equally, if you've got something that isn't working, if you've got outcomes that are not great, don't just accept that and keep doing the same thing. As Albert Einstein has said, if you always do what you always did, you will always get what you always got. And that's a really important thing to have at the back of your mind is there a better way of doing this, whether that be in surgery, in day-to-day care, in sports, in whatever it is that you're doing. And particularly for us as clinicians, the next really important principle is to make sure that you're keeping the patient at the centre of everything that you're doing. There is no point in us innovating for innovation's sake. The innovation that we have to introduce has to be of benefit to the patients that we're seeing and treating. And very often, you need to ask the patient what it is that they want, rather than assuming that you know what's best for the patient, because very often you will be wrong. I want to take you through in the next section a few of the innovations that I've introduced, the early phase innovations that were addressing problems for which we didn't seem to have adequate solutions, and we tried to find alternatives. So Peter Essex-Lopresti was a remarkable person, died unfortunately at the age of 35, but in his short life, he had served in the armed forces. He'd, I think, done something like 400 parachute jumps. He had been the Hunterian lecturer at Glasgow University. He described the ankle fracture classification, which has stood the test of time. But he also posthumously described this lesion, which is an injury which is sustained by falling from a height onto an outstretched hand and shearing between the two bones of the forearm. So the radius and the ulnar in the forearm, which are normally tightly held together by ligaments, becomes separated. And the traditional way of managing these injuries was to cross-pin between the radius and the ulnar, keep them in position, replace the radial head at the top, which was broken, and then hope that everything would just gum up and get sticky and everything would be fine. But the reality was you took the pins out, the radius kept moving, and then they go through a cycle of multiple surgeries while their arm is getting shorter and shorter, the hand is moving towards the elbow, and they're in constant pain. So we had to think about this and thought, well, how can we do things differently? What is the fundamental problem that we need to address? And the analogy I like to make here is that if you think about the ulnar bone as the door frame, the door post, and the radius as a door, the fundamental problem is that the hinge between the two has been broken. And so if you've broken the hinge, trying to hold it with sticky tape is not going to keep it in position. The forces are huge that go through the ligaments, and eventually the door just falls towards the floor. So what we need to do is to reproduce the native anatomy. We need to design a procedure which is strong, it's robust, it's anatomical, and so it reproduces the forces, the neutralizing forces that were there previously. And so we designed this technique of reconstructing the hinge, the ligament between the two bones, and conducted that in a series of patients and reported our experience. The patients did well, pain scores, the anatomy was restored, but you never get as good an outcome with that sort of situation as you would have got if you treated them well in the first place. And so that's been a key lesson, is to try and intervene early. Likewise, for these sorts of patients, this is a patient who's keen on working out, I think it's fair to say, and has torn his biceps on the right side at the distal end and has come with pain and cramp in his biceps. And we thought about, well, how can we address this? The traditional technique was to stitch a graft onto the top of the biceps, and what would tend to happen is it would just shear off over time. And so we considered, well, maybe what we need to do is to actually create a weave of tendon into the native tendon and then reattach it. And that's, we reported our experience with that. Again, really satisfied patients, good outcomes, and it's become a very reliable technique that others have adopted. And then the other more recent innovation was treating patients who have a painful arthritis in this part of the elbow, where they're typically manual workers. Every time they use a hammer, lift things, they get pain in that joint, and that can restrict their activities. If it's very sore, people have tried replacing the joint, but that was really produced an unpredictable unpredictable outcome. So we considered, well, what is the fundamental problem? The fundamental problem is that you've got a painful arthritic articulation, but around it you've got a really healthy joint that actually should function really well. You don't want to replace that joint. You want to try and preserve the joint, because this is a young person who wants to work and continue to do their manual activities to maintain their income. So that healthy joint needs to be preserved. And so we designed an operation where we would remove bone using a keyhole arthroscopic technique and just shave away that bone and create space in the damaged part. So a really simple solution, but one that people hadn't tried before. And again, we've reported our experience with that, which seems to provide good pain relief and enable people to keep working. So these are innovations that we've introduced, but the question is, well, what happens next? It's all very well me trying this in patients, but if nobody else is using those techniques, then we're not serving our population, we're not moving elbow surgery forwards. And the traditional way that innovation has gone is that somebody has an idea, they tell their mate tells their mate, and who tells their mate, and then somebody else hears about it. And possibly during that process, the original procedure gets changed a bit, because it's a bit like Chinese whispers. And so eventually what people end up doing may not be what was actually originally intended or described. Or people get up in a forum like this and share their experience, and somebody in the audience thinks, oh, that sounds like a good ruse, I'll go and have a go at that on my patients. Clearly not a great way to innovate or to disseminate and expand our knowledge, and clearly is fraught with problems. And John McKinley put it very well, that after some period of time, ever so gradually, there's an erosion of support that sets in. Enthusiastic claims made in earlier stages are modified, and what was thought to be universally applicable becomes only for certain populations and certain types of illness. And this is a really slow way of doing things. A really good example of this, so this is from hand surgery, was a type of finger joint replacement, which were being put in small numbers by a few people around the UK, until there was a presentation at the British Hand Society, and somebody presented their results, which weren't great. At least they were being honest, but their results weren't great. And then a few people in the audience said, actually, my results aren't great either. You know, I've done one or two, and one has had to come out. So then they thought, well, maybe we should actually all get together and have a look at what the outcomes of the surgery is. And what they found was that essentially there was about a 50% failure rate of that surgery. But then nobody was aware because they were only doing 1 or 2 procedures. And if they had a failure, they thought, well, one failure could happen to anybody. But actually, if you add them all together, it was a 50% failure rate. And there's a well-known phenomenon called the Scott's parabola. And that is where you start off with a really promising idea. People are very cautious to start with. They say, well, it's only possibly of value as a research tool. But then you generate a few encouraging reports. Then there's widespread enthusiasm. Somebody's given a talk at a conference and everyone thinks that sounds great. Then there's strong media pressure for universal acceptance, general introduction, until it becomes the standard of care. But hang on, doubts are starting to creep in. A few reports are coming through of things not going quite as well as you might have thought. Then you get some damaging survey reports, widely publicised medical legal cases. It gets condemned by several authorities. And then people decide it should only be used in very specialised circumstances. Finally, it falls into disuse. The theatre staff are wondering what on earth they're going to do with all this redundant kit. And the old surgeons can entertain the juniors with rollicking stories of what they used to do in the old days, but wouldn't possibly dream of doing in the future. And of course, that is replicated time and time again with different interventions. So in 2016, a new framework was proposed called the Ideal Framework for Surgical Innovation. And the idea was to give some structure, a bit like in drug development, to surgical development. So stage 1 is the idea. So that's the individual surgeon thinking, well, this could be something of value to the surgical community and to my patients. They have a go with a small group of patients in an ethical, suitably ethical manner. And they try it out and they see if it works in their hands. They then go to early adopters, a smaller group of highly specialised surgeons, and they try the technique in their hands. And they might change the technique. They might find that there are things that they find work well, and the technique might evolve and develop. It then goes to a broader group of surgeons, maybe slightly less specialised, but still high volume, and we start to collect patient outcome data, again, examining the safety, before you eventually get to a randomised controlled trial where you compare the intervention to another intervention or the standard of care, and then finally surveillance, so long-term studies. And the idea of this framework is to accelerate the development and the expansion of innovations in a structured way so that there is less waste. The Scott's parabola doesn't keep going around in a circle, and that things that don't work are abandoned early, and the things that do appear to work are explored further. And we can add into that a stage 0, which is a cadaveric study where we see in a cadaver lab how do we do the surgical approach, what are the techniques for developing the procedure. And an example of that is the Happy Elbow project. It sounds great. Unfortunately, Happy stands for hallux pyrocarbon, so it's a use of a toe implant. But the operation is to address patients. Again, these are patients of working age, typically in their 50s. They have elbow arthritis, painful, stiff elbows that are preventing them from working. And particularly, they have involvement of the ulnar joint, so the central part of the joint. And we've really had no solution to that problem. We can give them painkillers, we can give them splints, but and we can inject the elbow, and that can provide relief on a temporary basis, but it's not a lasting solution. They'll not normally come back after a few months. I said I'd removed all the blood and guts, not entirely all, but there is a technique that has been used called interposition arthroplasty, where you open up the joint and you resurface the joint, damaged joint surfaces with a tendon graft. But the outcomes for that really are not good. They're very unpredictable, with only about a third of patients actually being improved following the surgery, which isn't a really good odds. You could, of course, do an elbow replacement in those patients, but if they're of working age, it's very likely that the elbow replacement would fail. And our own research has shown that if you're young and you're male and you've got osteoarthritis of your elbow, then an elbow replacement is going to fail sooner than it would otherwise. And we've already agreed that you don't fuse an elbow because you can't get your egg up to your mouth and enjoy the taste of that. So, and therefore you can't survive, you can't really function. So is there an alternative? Well, we considered the patients that had failed total elbow replacements, and for those what we would tend to do is to put in a spacer, because especially if they had infection, so that we could stage the surgeries, try and eradicate the infection. This would be a spacer made of cement with antibiotics. And what we found is that as long as they had enough bone, that they would actually function perfectly well. And many of them would come to us and say, well, actually, I don't need another elbow replacement because I've got this ball in my elbow and it's working perfectly. And it's a little bit wobbly, but it's not painful. And it got us to thinking, well, maybe for our young 50 arthritic patients, this would be a good solution. So we took this toe implant and we thought, well, what if we put that into the elbow? A bit like a Dyson. You know, you can have the elbow moving on a ball. It had been tried in other joints, in finger joints, in shoulder joints, as I say, toe joints. And so we went to the cadaver lab, did our stage 1 study with the engineers from the company. We designed the surgical technique. We implanted the sphere into the elbow and were pretty satisfied with the way the elbow worked. We kept the ligaments intact. So we thought, well, next thing is how do we introduce this into patients? But the problem we face is that there was no real framework for how you do a stage 1 trial. So what we're proposing to patients is we're going to do something which is completely new, completely different. Nobody's ever done it in the human before. And is that acceptable? Is that a reasonable thing to do? So we had to design a structure for us to do that. And we thought the best place to start was to go to the patients and speak to them and say, if you've got an arthritic elbow, is it a reasonable thing for us to ask you to take part in a trial of something that may or may not work? We really had absolutely no idea. And if you were to go into that trial, what would you want us to tell you? What would you want us not to tell you? And how should we structure it and design it? And we got really useful information from the PPI group. And in particular, they said, look, if you think that this is something that could help, it's entirely reasonable to offer it to patients as long as you give them all the information. So we then designed our protocol and our patient information sheets. And we sent it to somebody who worked outside the trust, to another elbow surgeon who's completely independent. And a lot of people would be scared about doing that, worried that somebody else is going to steal your idea. So you have to choose your external reviewer carefully. But actually, most people are very honest and are not going to do that. And it's really useful to have a fresh pair of eyes. And the external reviewer made some really sensible amendments and suggestions to our protocol and the way we were going to tackle things. And then we went finally to an ethics committee to say, well, look, this is what we're proposing, this is what we would like to do. Is it ethical? Is the way we're approaching this reasonable? And it was handled extremely well through the ethics committee, and we were able to proceed. And so this is the first patient who had the elbow implanted. This is a live X-ray screening of the elbow being moved through a range of movement. We've been really conservative. We haven't tried to increase their range of movement, but we've just tried to improve their pain. And in the early phase of this trial, up to 6 months, we're following them for a total of 2 years. We have shown improvements in pain. we've shown improvements in function. One patient has reported persistent pain, and that is difficult for him, difficult for us, and is a situation that you will often find in surgical trials. But we haven't had any major complications, readmissions, or reoperations. So for a phase 1 trial, we can conclude that this is a safe thing to try. If it doesn't work, well, we have solutions, but it's something that's worth considering. And Ben has been working here, doing motion analysis on these patients and shown that their motion is preserved. And we've also asked them a really key question. If you were, if a friend or family member had the same problem, would you recommend this to them? And we use something called the net promoter score, which is where if they score 9 or 10, then they're considered a promoter. If they score 0 to 6, they're considered a detractor. And we subtract the proportion of promoters from the proportion of detractors to end up with a net promoter score. And here, for this intervention, small numbers, but actually the net promoter score is 100, which is not bad. So it seems that the patients feel that they're getting some value from the intervention. You always have to be careful, because of course, if you go and buy a car, you always think that's the best car that's ever, nobody is ever driving a car that they're ashamed of. Everyone thinks that it's the best car that's ever been put on the road. But over time, we will hopefully explore whether this is an acceptable intervention. But the next stage is obviously to see whether the technique works in other people's hands. And that's a really key step. And then we expand it out before we progress to a stage 3 randomized controlled trial. Of course, randomized controlled trials are the gold standard for assessing an intervention. It's comparing it to a control or to another intervention to see how the outcomes compare. It enables us to limit bias that might be seen in other trial designs. I'm very grateful to Jeff Hooper, who was one of my early trainers when I started in orthopaedics, who introduced me to randomized controlled trials. We had a problem of patients who were having nerve surgery, carpal tunnel surgery. When they had the injection to numb their hand, they didn't like the pain of the injection. And we thought, well, maybe one of the reasons they're getting pain is that the local anesthetic that we inject is an acid. It's an acid because acids it prolongs the shelf life of the local anesthetic. And so we wondered, well, what if we changed the pH, what is red to green, that's going to neutral, then we can hopefully reduce their pain from the injection. And we showed that in a randomized controlled trial, we were able to reduce the pain scores. It taught me about randomization. It taught me about masking of patients to the intervention and masking of the surgeon. It taught me about writing protocols and really valuable things that you need to be able to run a randomized controlled trial. It also taught me that you can get really unexpected things happening when you do a trial. So we asked them very simply, I thought, just to score pain from 0 to 10 with a line crossing this line, a vertical line crossing this line, indicating the pain scores. We had lines going parallel to the line, we had circles, we had crosses, making it quite difficult to know what their pain outcome was. But it taught me that you should never assume anything and that you must always speak to your patient group and find out whether the way you're communicating is clear and whether you will end up with the intended outcome that you're trying to achieve. Later on in my career, when I started here at Wright Hospital at WWL, we designed a trial looking at proximal humerus fractures, shoulder fractures. Here we had a problem that the traditional technique for addressing these injuries was to do a hemiarthroplasty, so half a joint replacement, as in this picture in the middle here. But there was a new operation at that time, which was to replace both sides of the joint, but change the anatomy so that you make the cup on this side and the ball on that side, rather than the normal anatomy where the ball is on this side and the cup is on this side. And it's called a reverse shoulder replacement. And so we designed a randomized controlled trial. And this was novel for me in that it was a multi-center trial. And we got money from industry to do this trial, and I thought we were doing well. We're on our way. I think it was about 170,000. That is nowhere near enough to do a multi-center randomized controlled trial. And that was an important learning point for me, apart from all the challenges of doing trials in centres which are distant to where you're working, and the challenges of data control in that way. But these are trials outside of the elbow, and my passion, as I said, is the elbow. So I want to talk to you about a big trial that we've just completed, which was a trial looking at olecranon fractures. This is fractures of the point of your elbow. So when you fall onto your hand or fall onto the elbow, the triceps either pulls that piece of bone off, or you just break it off by the force through the elbow. And that means that the pull of the triceps is no longer working the elbow, and therefore you struggle to extend. And so the traditional approach for these injuries is to put in metal wires and screws, metal wires and a cerclage wire to hold the fracture reduced, while nature does the rest and heals the fracture. And that technique works pretty well, but there is about a 35% reoperation rate, because people can feel the metalwork under the skin here. Every time they lean on their elbow, they get pain. And so about 35% go on to another operation. And you can say, well, so what? It's a minor operation, it's taking out the metalwork. But every operation is a major life event for that individual. And it's a cost to the National Health Service, and it means that somebody else can't be using that theatre slot for another operation. So if we can reduce that rate of reoperation, then that would be a benefit. I went to the British Elbow and Shoulder Society meeting, and somebody presented a technique using anchors, which are designed for fixing soft tissues. And I looked at that and I thought, well, that looks very interesting, but it's quite expensive, and I think we could probably do that more simply. And so we designed a technique where you just drill through the ulna and then use soft sutures, just stitches, to fix the fracture, basically transferring the force of the triceps, which is pulling that bit of bone off, and transmitting that force distally so that the bone is held in position. So we went to the CAD lab, we tried it out, and it seemed to work. We loaded the elbows, having fixed the constructed fractures, and it seemed to hold the bone in position. So we went then to the patient group, and we went through the process of trying this in a small group of patients at WWL, and it seemed to be working. We had one failure of fixation, which was a technical mistake on my part, but the majority of the patients did extremely well. So then we went to our phase 2 trial. We went to other centres, and to see whether people would change the technique that I designed, or whether it worked in their hands. And we found that the reoperation rate was much lower using this suture technique compared to using traditional techniques of wiring and plating. So we thought, well, now is the time to go to a randomized controlled trial. And it's often said, well, there is never a good time, because it's often said that it's too early to go to a randomized controlled trial because it's still being developed, or it's too late because now everyone's using the technique anyway, so you can't go back and try the old technique. So finding that sweet spot when you're actually going to go and evaluate the new intervention is difficult, but we felt that we hit the timing was right. And this was a daunting thing for me, because I recognised from my past experience that I needed money, and I needed quite a lot of money. At that time, there was a programme through the British Orthopaedic Association who were supporting people to develop trials through York Trials Unit. And with their support, and all of these names were vital in securing this funding. We were able to get funding from the National Institute for Health and Care Research to enable us to do this trial. It was supported by the British Elbow and Shoulder Society and the Orthopaedic Trauma Society. And we compared in 280 patients the new technique using just sutures to tension band wiring, the traditional technique. Our populations were balanced in both arms of the trial in terms of age and gender and in terms of hand dominance. As is common, unfortunately, in most trials in the UK, 95% of our population were white, and that is a problem in how we engage minority groups. And we were balanced in the number of smokers and the number of drinkers, because these are things that can affect the outcome. And this was in this type of trial, we're not trying to show that the new technique is better. We're just trying to show that it's no worse than the traditional technique. So it's called a non-inferiority trial. And so before at the outset, we said, well, the minimal clinically important difference is 10 points using the instrument called the DASH score that we were using. And therefore, we have to be within 10 points of the traditional technique to be an acceptable alternative. And what you can see here at 4, 12, 18 and 24 months, the difference in the scores is well within that 10-point barrier. In fact, our 95% confidence intervals are well within that 10-point margin. So we can be pretty confident that really there is no difference in the outcome using this instrument. We also looked at pain, and there was no difference at any time point between the two groups. We did find that they were a bit slower to heal, so more were not healed at 4 months, but it didn't affect the outcome in the long term. None of them went on to have further surgery because of non-union. And most importantly, there was a significant reduction in the number of reoperations. So our hypothesis was that if we used a suture technique, we could reduce reoperations, was supported, and the patients hopefully have benefited by not needing to go back for further surgery. And importantly, so the NIHR put in 1.7 million to support this trial. We've shown that if everybody adopted this technique, we would save about £4 million a year for the NHS. So that money can be recouped and reinvested. So it was significantly cost saving. And importantly, the net promoter score, for the red line is the new technique, the blue line is the old technique, and the net promoter score is over 80. It's even better than an iPhone. So what's not to like? So we've used here a standard frequentist approach. So we've used the technique where you can either do an explanatory trial or a pragmatic trial. We chose a pragmatic approach because we wanted to see how it worked in the real world. And the frequentist approach is the standard, typical approach that most people are using for randomized controlled trials. The problem with that is that it ignores anything that's gone before, any prior information. You need really big numbers of patients to answer the question typically, unless your effect size is very big. And it costs a lot of money. And that's a big problem because especially for things like elbow surgery, there isn't a lot of money swilling around. But is that the only problem? Well, a lot of people point the finger at us, the orthopaedic surgeons, and say, actually, that's not the problem. You're the problem, because you all think you know what you know best. You all believe that you've got the perfect solution to every problem. You all think you're gods, and you're clearly not. And a bit like the Wizard of Oz, we're all hiding behind this image because the reality is there's a terror. And the terror is that most of what we do in orthopaedics, we have very little evidence to support. And is that because we're not bookish enough? Is it because we're just carpenters with our hammers? Or is there another problem? And I think it's the latter. And the real issue is that, first of all, surgeries are complex interventions. It's really difficult to standardize surgery. There are so many different factors. It's not just me and what I'm doing in the operating theatre. I've got a nurse who's helping me. If you've got a different nurse, that can change things. Different theatre environment can change things. Different anaesthetist, different hospital. There are so many different parameters that come into play that can change the intervention. So surgical culture may be a problem. Equipoise may be a problem if we all believe that we know best and that we don't need trials to answer the question. That can be an issue. There can be issues with learning curves. If you're trying to introduce a new technique, then somebody's got to learn it before you trial it. Defining exactly what the intervention is, the surgeon's experience. And there can be issues with patient equipoise. So I just want you to consider this. If I was offering you a trial where the intervention is roughly equivalent, such as in the trial which we've just done, you'd probably be reasonably happy to enter into that trial. If you said, well, they're pretty much the same operation, just a minor variation, certainly the same sort of intensity, you'd think, okay, I'm not that averse to going into that. But what if I'm comparing a minor procedure to a major operation, and we're asking you as a patient to be randomized to minor or major? You might be a little less in favor of going into that trial. What if I'm comparing surgery to physiotherapy? You as a patient may be very much of the view, I don't want an operation, I want physiotherapy. So are you going to be prepared to be randomized to where you've got a 50-50 chance that you might end up in the surgery group, or vice versa? And the surgeon might have a loss of equipoise there and feeling this patient definitely needs an operation, or this patient definitely doesn't need an operation, because we're going to get a problem with the outcome. So that could be a real challenge to recruitment. And then imagine the scenario where we're doing the control is a sham operation. So I'm going to put you to sleep, I'm going to cut into you, but I'm actually not going to do anything that's therapeutic. Do you really want to be randomized in that trial where you're going to have a cut, but a wound to your skin, left with a scar, but actually nothing is being done? Amazingly, patients do sign up to those sorts of trials. In some ways, it's the gold standard, but really hard to do. So that is a problem. But I think, particularly in orthopaedics, that there is an even bigger problem, and it's an unrecognized problem. If we are doing drug trials, the European Union defines a rare condition as less than 50 in 100,000. And they recognize that it's really difficult to do trials in populations with that low frequency. And so they give extra funding for drug trials if the condition is rare. A few of the only procedures we do are hip and knee replacement. That's about 150 and 100,000. Elbow replacement surgery, the sort of thing I do, is 0.7 in 100,000. So is it any wonder that we struggle to do randomized controlled trials if that's the frequency of the population? And we've looked at this and looked at the trials in orthopaedics. That's the threshold for rare diseases. This is a list of conditions, of orthopaedic conditions and surgeries, and their frequency down the side, their incidence. And if we look at the trials that have been run, the UCUF actually ran to time. That was just below that threshold. Rhapsody, which is one of the trials that I'm involved in at the moment, is behind and will finish very late. We'll have had to extend our recruitment period for much longer than intended. The UK FROST trial looking at frozen shoulder had to go for an extra 5 months, more hospitals than intended. Seesaw, which was looking at impingement, pain for the shoulder, needed more hospitals, longer recruitment. And then the ankle replacement trial was actually had to recruit for 7.25 years compared to 4.25 as they'd intended. And I don't think there was anything sloppy in the way anybody had designed these trials, but I just think they hadn't recognized how rare the intervention that they were looking at was. And that's really important. So look at poor old elbows. right down here, and many of our conditions drop off the bottom of the scale. One example of that is this. This is a distal humerus fracture. So this is an elderly patient's injury. They fall onto their elbow, they smash their distal humerus, and we need to replace it because we can't fix it. And there are two types of replacement. You can do half a joint replacement or a total joint replacement. If we look in the literature, very little evidence. Basically, it's observational studies, case series, very small numbers. There are a few trials, but very small numbers. 41 patients, even 60 patients in a randomized control trial is not going to answer the question using frequentist approaches. And there seems to be pretty much equipoise amongst the surgical community because with patients having this surgery, 50% get a total elbow replacement, 50% get a hemi replacement or half a joint replacement. So it seems clear that we don't know what is right for these patients. And so it's ideal for a surgical trial. But how do we do it when the incidence is 0.2 in 100,000 of the population? We would have to get every single patient in the UK over about 7 years, and that's just not possible to do. So we could look at international trials, but given that it costs about 1.7 million to do a trial in the UK, can you imagine trying to do trials in countries around the world? It becomes really challenging. So we can look at the literature on rare diseases and look at other ways of doing trials. And in drug trials, they do crossover designs, so they change the arm within individual patients. You can't do that in surgery because you can't undo an operation. You can do N-of-1 trials, which is where you need a very early outcome to be able to know whether the intervention is working. That doesn't work in surgery. Likewise, adaptive designs. And really, when I looked into this, the only thing that might hold some promise is something called Bayesian trials. And this is good old Thomas Bayes, who also is a chap who died before his most famous publication. What he was a reverend and a mathematician, and he basically showed mathematically that you can, if you know the distribution of data before an intervention, and then you collect some evidence, you can use mathematical calculations to create a distribution of what the outcome is likely to be in that population. The great thing about that is you only need one patient to be able to update what you know about a subject. The other great thing about it is that we don't disregard everything we knew about the problem before as we do in a frequentist trial. So it really has a lot of potential for exploration in low volume surgical trials. It comes under criticism because if your prior belief is wildly wrong, you might update your prior belief to be closer to the truth, but you're still going to be wildly wrong, and therefore you may make some erroneous conclusions. But it's really very intuitive for clinicians because it's how we practice. When we're making a diagnosis, we're using Bayesian probability statistics without even knowing about it. Because when I take a history from the patient, I'm thinking, okay, well, that's the possible diagnosis. This is less likely. But if they, depending on how they answer the questions, this might be bumped up and this might be bumped down. The probability of this goes down, the probability of this goes up. When I then examine the patient, it might shift the balance again of probabilities. This is Bayesian statistics in action. And so it's very intuitive, and the probabilities and the outcomes that you get from Bayesian analysis are much easier for clinicians to understand than the outcome from a frequentist approach, which is where we're talking about the probability of rejecting the null hypothesis. And most people get completely confused about what on earth that means. So lots of advantages. It uses all the available evidence, it's flexible, and it's intuitive. There are challenges. It needs a lot of computing power, but I think that problem is addressed. The biggest problem, and I don't know if you're fans of A. Milne, but I grew up on this and the story of the brownie who you knew was there, but you could never find them. And that is true for Bayesian statisticians. We know they're out there, but finding one who can engage and work with you in trials is actually incredibly difficult. So that's the current challenge that we're working on. We're really proud to have created the MSK research group, and we've got lots of exciting trials in design, and we're looking to bring these Bayesian approaches to tackle these rare interventions and rare diseases. And this is really a work in progress, and hopefully something that is going to grow and develop and help the group to come together. I'm extremely grateful to my colleagues at WWL for all of their support over the years, and without them we couldn't have got to this point. And to my mentors, this is a chap called Graham King, who taught Greg Bain, who taught me about elbow surgery, and I'm very grateful to them. And of course, my family, very proud to have you here tonight, and I'm amazed you managed to keep your mouth shut the whole way through. It's a miracle. But it's good to have you here, and I'm very grateful for everything you do, putting up with me, and the fact I'm always away. So I said at the beginning of the talk, I'm a bit of a dreamer, but sometimes you need dreamers. You need dreamers who are doers, and that's what I try to deliver. Thank you very much indeed.
Just to say, for those who don't know me, I'm Jeremy Brown. I'm Professor of Clinical Education and Associate Dean for Research and Innovation here in the faculty. And really just want to formally thank you for not just this evening's lecture, but also the impact you're having here at Edge Hill in what is relatively a short period of time. Over the last year, it's been an absolute privilege to work with you. And I'm really quite excited about what's coming next in terms of the journey, in terms of your role personally, but also bringing others on within the university and wider afield. We have got time, I think, for just a few questions. So I know Ben's got a mic there. If anyone wants to ask Adam a question before we finish for the evening and move into the foyer.
Thanks, Jeremy.
Anyone got any questions?
Can I ask you a question to kick off in terms of talked about dreaming as for the school report through to your last slide. You mentioned about the dream about moving to be an elbow surgeon, but initially when you decided to go into medicine, did you know you wanted to be an orthopaedic surgeon?
I didn't actually know that I wanted to be an orthopaedic surgeon. I thought I probably wanted to be a surgeon. Unfortunately very stereotypical. I loved joinery and carpentry as a kid, and I loved dissecting. So when I went to medical school, you got given your cadaver on day one, and that filtered some people out. But for me, it was, it was an opening to a world that I loved really. And so I knew I wanted to be a surgeon. I thought actually I was going to be a plastic surgeon, but I then did plastic surgery. I didn't enjoy it, and did orthopaedics and absolutely loved it and never looked back. I think we're extremely lucky in what we do. We enjoy what we do. We have great patients and great colleagues to work with, and so I think we're very lucky, really.
Obviously, you've been on quite.
It's just for the ones online, that's all.
Oh, sorry. So hopefully I'm not too loud through this now. So it's clearly one massive journey that you've been on, Adam. If you were to go back and give yourself or any of us that are looking to aspire to get to that sort of level in the audience advice on what you would do differently or what the biggest challenges you've overcome or sort of ways to go about achieving that, what would they be?
So the biggest lesson I've learned is teamwork. So my skill is being an orthopaedic surgeon, and that's what I can bring to trials. I can dabble in statistics and I can dabble in trial design, but there are experts in those fields, and there are experts in physiotherapy and other areas. So you want to bring a team together of experts to help you to deliver your research. It's much more fun working in a team, but actually you're always going to deliver a better trial, better product. And one thing will lead to another, will lead to another. So never be afraid to reach out and speak to people. There is nobody who is not approachable, and you will always find that people are willing to engage and help you to build that team around you. Because ideas will come from all over the place, and sometimes you may come up with 100 ideas and only one of them is good. But actually, that's great, because we only need one good idea, and that can make a difference. So teamwork, definitely. Get a good team around you. Thanks very much indeed. Thanks, Jeremy.